Lumbar disc herniation, spinal stenosis, and spondylolisthesis are common conditions affecting the lumbar spine. These conditions can cause significant discomfort, impair mobility, and reduce the quality of life if left untreated. Understanding the anatomy, pathophysiology, clinical manifestations, diagnostic methods, and treatment options for each condition is essential for effective management and patient education. The lumbar spine, composed of 5 vertebrae labeled lone through 5, supports much of the body's weight and allows for various movements, including flexion, extension, rotation, and lateral bending. Between each vertebra lies an intervertebral disc, which acts as a cushion, absorbing shocks and facilitating smooth movement. Each disc comprises a tough outer layer called the annulus fibrosus and gel-like inner core known as the nucleus pulposus. When the structural integrity of these components is compromised, conditions like lumbar disc herniation can develop. Lumbar disc herniation occurs when the nucleus pulposus protrudes through a tear or weakening in the annulus fibrosus. This herniation can compress nearby nerve roots, leading to symptoms such as lower back pain, radicular pain sciatica, numbness, tingling, and muscle weakness. The severity and distribution of symptoms depend on the location and extent of the herniation. For example, a herniation at the forefive level often affects the fave nerve root, causing pain and sensory changes in the lateral thigh, calf, and dorsum of the foot. The pathophysiology of lumbar disc herniation involves both mechanical and inflammatory components. The mechanical compression of nerve roots leads to impaired nerve conduction, while the release of inflammatory mediators from the herniated disc material exacerbates nerve irritation. Over time, the combination of mechanical and chemical insults can result in significant neurological deficits if not appropriately managed. The clinical presentation of lumbar disc herniation varies, depending on the degree of nerve compression. Patients often report lower back pain that radiates down one leg, commonly known as sciatica. The pain typically follows the dermatomal distribution of the affected nerve root. Sensory changes, such as numbness and tingling, are also common. In more severe cases, motor deficits, such as foot drop or difficulty walking, may occur. Additionally, patients may experience increased pain with activities that increase intra-abdominal pressure, such as coughing, sneezing, or straining during bowel movements. Diagnosis of lumbar disc herniation begins with a thorough clinical evaluation, including a detailed history and physical examination. Special tests, such as the straight leg, raise SLR test, and the crossed SLR test, can help identify nerve root irritation. Imaging studies, particularly magnetic resonance imaging, MRI provide detailed visualization of the intervertebral discs, nerve roots, and surrounding structures. Computed tomography (CT) and myelography can also be useful, especially if MRI is contraindicated. Treatment options for lumbar disc herniation range from conservative management to surgical intervention, depending on the severity of symptoms and the patient's overall condition. Conservative management typically includes rest, nonsteroidal anti-inflammatory drugs and NSAIDs, physical therapy, and activity modification. Physical therapy focuses on strengthening the core muscles, improving flexibility, and promoting proper posture. Epidural steroid injections may provide temporary relief by reducing inflammation around the affected nerve root. Surgical intervention is considered when conservative measures fail or when significant neurological deficits, such as progressive weakness or bowel and bladder dysfunction, develop. The most common surgical procedure for lumbar disc herniation is microdiscectomy, which involves removing the herniated portion of the disc to relieve nerve compression. Minimally invasive techniques have gained popularity due to their shorter recovery time and reduced risk of complications. Spinal stenosis is another common condition affecting the lumbar spine, characterized by the narrowing of the spinal canal or neural foramina, leading to compression of the spinal cord or nerve roots. This condition is often associated with age-related degenerative changes such as disc bulging, facet joint hypertrophy, and ligamentum flavum thickening. Lumbar spinal stenosis typically presents with neurogenic claudication, characterized by lower back pain, leg pain, and weakness that worsen with walking or standing and improve with sitting or leaning forward. The pathophysiology of spinal stenosis involves both mechanical compression and vascular compromise. As the spinal canal narrows, the blood supply to the nerve roots becomes compromised, leading to ischemia and nerve dysfunction. This vascular insufficiency contributes to the characteristic symptoms of neurogenic claudication. Diagnosis of lumbar spinal stenosis involves a combination of clinical evaluation and imaging studies. Physical examination often reveals diminished lower extremity strength, sensory changes, and abnormal reflexes. Imaging modalities such as MRI and CT provide detailed visualization of the spinal canal and neural foramina, allowing for accurate diagnosis and assessment of severity. Treatment for lumbar spinal stenosis depends on the severity of symptom and the patient's overall health. Conservative management includes physical therapy, NSAIDs, and activity modification. Epidural steroid injections can provide temporary symptom relief by reducing inflammation around the compressed nerve roots. When conservative measures fail, surgical intervention may be necessary. The most common surgical procedures for spinal stenosis include laminectomy, laminotomy, and minimally invasive decompression. These procedures aim to widen the spinal canal and relieve nerve compression, thereby alleviating symptoms and improving quality of life. Spondylolisthesis is a condition characterized by the forward displacement of one vertebra over the one below it. This condition can result from congenital defects, degenerative changes, trauma, or pathological processes. The most common types of spondylolisthesis are degenerative and ischemic. Degenerative spondylolisthesis typically occurs in older adults due to facet joint arthritis and disc degeneration, while ischemic spondylolisthesis usually results from a pars interarticularis defect, often seen in younger individuals. The pathophysiology of spondylolisthesis involves instability of the affected spinal segment, leading to nerve compression and mechanical back pain. As the vertebra slips forward, the spinal canal and neural foramina narrow, resulting in nerve root irritation and radicular symptoms. Clinical manifestations of spondylolisthesis include lower back pain, radicular pain, and neurogenic claudication. Patients may also experience muscle spasms, limited range of motion, and postural changes. In severe cases, significant nerve compression can lead to neurological deficits, such as weakness, numbness, and bowel or bladder dysfunction. Diagnosis of spondylolisthesis involves a thorough clinical evaluation, including a detailed history and physical examination. Imaging studies, such as plain radiographs, MRI, and CT, provide valuable information about the degree of vertebral slippage, nerve compression, and associated degenerative changes.
Dynamic radiographs, including flexion extension views,
can assess spinal stability and guide treatment planning. Treatment for spondylolisthesis depends on the severity of symptoms, the degree of vertebral slippage, and the patient's overall health. Conservative management includes physical therapy, NSAIDs, activity, modification, and bracing. Physical therapy focuses on strengthening the core muscles, improving flexibility, and promoting proper posture to support the spine and reduce pain. Epidural steroid injections may provide temporary relief by reducing inflammation around the affected nerve roots.
Surgical intervention is considered when conservative measures fail,
or when significant neurological deficits develop. The most common surgical procedures for spondylolisthesis include spinal fusion and decompression. Spinal fusion aims to stabilize the affected segment by promoting bone growth between adjacent vertebrae, while decompression relieves nerve compression by removing bone or soft tissue, impinging on the nerve roots. Postoperative rehabilitation plays a crucial role in optimizing outcomes for patients undergoing surgery for lumbar disc herniation, spinal stenosis, or spondylolisthesis. Physical therapy focuses on restoring strength, balance, and coordination while addressing residual pain and stiffness. Patients are encouraged to maintain an active lifestyle and practice good posture to prevent recurrence. Regular follow-up with imaging and clinical assessment ensures that the condition remains stable and that any signs of recurrent compression are promptly addressed. In conclusion, lumbar disc herniation, spinal stenosis, and spondylolisthesis are complex conditions that require a comprehensive understanding of spinal anatomy, pathophysiology, clinical presentation, diagnosis, and management. Early diagnosis and appropriate treatment are essential to prevent long-term disability and improve quality of life, while conservative management is often effective for mild cases. Surgical intervention may be necessary for severe cases. To relieve nerve compression and stabilize the spine, educating patients about the importance of early intervention, lifestyle modifications, and adherence to treatment plans can significantly enhance outcomes
and ensure long-term spinal health.